attending this special symposium from the Bessens Healthcare Group. And we wish to welcome you to this symposium with the intriguing title, How We Unravel the Black Box in Luteal Phase Support in Reproductive Medicine. And let's start with introducing ourselves, as we are the two chairpersons for this symposium. My name is Frank Broekmans from the Netherlands. I am a retired professor of reproductive medicine of the University Medical Center in Utrecht, but I also have been, or are still, a consultant in reproductive medicine in the brand new IVF Center in Purmerend in the Netherlands. And I truly ask my co-chair now to introduce himself. Peter.
Hello to everyone. I am Peter Humaydam. I'm a professor in reproductive endocrinology from Denmark, from Aarhus University, and I'm very happy to chair this session as I've spent quite a lot of time and work on luteal phase.
Okay, thank you, Peter. It's very nice to know that you will be my supporter and I will be your supporter. These are our disclosure slides on all the speakers that will attend this meeting. And then this symposium is on progesterone luteal support. And the title holds the term black box. And what we mean by black box is that we still face this magical mystery process of the embryo implanting. And today we still not have maybe a single clue of how the endometrium and the embryo together fix it to the implantation. But there is some good news because in this black box of implantation, progesterone is our light in the dark of the black box. And indeed, we use it more and more in our treatments. We use it in frozen embryo replacement cycles, starting at the bottom of the slide. We prefer natural cycles for our embryo replacement today, but even in artificial cycles, we clearly need progesterone as a tool. But we also need it in IUI with mild stimulation, based on the Green Review. And today, still, we are performing a large randomized trial with support from Bessens in the Netherlands to reinforce these green findings and to improve the quality of the evidence. And today we even are anxious to know whether progesterone will even help us out in couples with unexplained infertility who still have a reasonable chance of getting it to a baby themselves, but with luteal phase progesterone we may even improve their prospects for a child within 6 to 12 months with this luteal support. And we truly hope that we get support from our national funding bodies to finance the Plume study, which will extend on the work that has been done by Devonport and was presented on the ESHRE meeting in Denmark last year. But of course our best friend progesterone is in the fresh cycle in IVF and ICSI hyperstimulation cycles, because there, in contrast to the other treatment areas, we created the luteal dysfunction by our LH peak suppression protocols. So there we see this old friend in its best action. So, as there is not nature, we create this luteal dysfunction, and this good friend of us helps us out. So, Peter, do you agree upon this role of progesterone in our work?
Yes, Frank, actually I do.
I hope so.
So, I just want to remind all of you that if we just go back 15 years, no one had a specific interest in Luteal phase because we were in the belief that whatever we do is enough. We treat our patients in fresh transfer with HCG. We then started the agonist trigger and we failed big time initially, 2005. But at the end of the day, this was what opened the whole Luteal phase. But because what we saw after the agonist trigger and fresh transfer was a 75% reduction in progesterone, serum progesterone, which meant that we lost 80% of all pregnancies. So actually, the reason why we are here today is what started up as a catastrophe in 2005. So, as this slide tells you, well, we are slowly getting more and more knowledge about the Luteal phase and how to treat, but we're still not there. There's still new issues coming up. We talk a lot about progesterone. A recent paper by our group also shows that actually estradiol plays a significant role. These two steroids will work in synergy, and we just have been focusing on progesterone. Now, and you could say, come on, Peter, what is this? 2 patients, 1 patient on each slide, 3 different cycles looking into corpus luteum function. Now, for those of you who are not into nanomolar, this 30 nanomolar is 9.4 nanogram per mil, and this is the level suggested by Michael Hall already back in '82 to be predictive of natural ongoing conception. So the 10 nanogram we are talking about today is nothing new. We knew this 40 years ago, but it's been reinvented. So what I wanted to show you here with these two patients is that through 3 cycles, you can see only 1 cycle actually reached the 9.4, and here significantly higher, 60 nanomolar. But all the other cycles were deficient, and this is natural cycle. And this is why when we do natural, so-called natural cycle frozen embryo transfer, we lose 10% live birth rate if we don't add Luteal phase support, because the question is, can we rely on corpus luteum? No, we cannot. And the problem is measuring the progesterone in a natural cycle is extremely difficult because you're going to have pulses and you're not going to get it right. So today we want further to open the black box, and the questions here we will try to answer are there enough indicators that we should monitor progesterone levels, and also to touch upon this new idea of frozen embryo transfer, a combination of natural cycle and artificial cycle, taking the best from all. I predict this is going to be the new change. So, without further ado...
So you will introduce the new speaker, and
yes,
I go there.
Yes, please. So without further ado, I'd like to introduce the first speaker to you, who is a good friend of mine, Dominique de Stoep. He's a professor, and he's head of the Department of Reproductive Medicine in Ghent. He's also the president of the Belgian College of Physicians in Reproductive Medicine. Now, he actually prepared a very comprehensive update on Luteal phase support, and I also think he's going to go into the issue how, when, and maybe also where to put the Luteal phase support. So please, Dominique.
Thank you, Peter, for this kind introduction, and good afternoon to you all. So, the black box of Luteal phase support. So the last couple of years, we've been slowly opening that box. It's just not that we're going to do this today. It's been happening for the last couple of years, and we're learning by doing studies and by reading papers. And it appears not to be a Pandora's box. So all what we find in there is actually making treatment outcomes significantly better, and has shown it's one of the places in our field that we can actually make a difference and increase implantation in a significant way. But if we would open that box completely and we shed a light into the box all the way to the bottom, and we have a huge magnificator and see what's down there, we would see a 21 carbon atom molecule which is called natural progesterone. And what does progesterone do? of course, and that's what you all know, it is changing our endometrium. It's preparing it for implantation. And it's something so important that we can actually visualize this when we do our scans. We see the trilaminar layer going to impacted, dense endometrium. But it's not only what we see, also what we do not see. That's very important. And so not only on the crime scene of implantation things are changing, but also further away our whole immune system is getting ready for implantation. Cytokines are attracted, even our body temperature or the body temperature of the woman increases. Now also the uterus has its role. So the myometrium, basically the uterus has to sit back and relax and let the guest embryo implant. And that's nicely shown by studies by Renato Fanchin, who has shown that if progesterone increases in the blood, so the serum progesterone increases, the uterus tends to calm down and allows the embryo to implant. And it's also been studied with the waves that you can now measure by ultrasound. Another thing in its role, and as something which has been more prevalent in literature last couple of years, but basically isn't that new, because even I think Frank Broekmans has published on this years ago, is that progesterone is also active in the follicular phase. But basically, luteal phase starts from ovulation, but in the day or days before ovulation, we see progesterone significantly increase. It's not spectacular, it's not as after ovulation, but it has a significant increase and also significant enough to make a difference. It has its difference on the endometrium probably, slowly preparing the endometrium for being receptive and the timing of that process, but also it basically helps to trigger ovulation itself by ESHRE later on. This aspect of the progesterone's role will also be discussed by the next speaker, Samuel. Now, let's first have a look at the fresh embryo transfer, because this is the most complicated, most challenging situation for our embryos, because we've been doing everything to get as many eggs as possible, to create these embryos for implantation, but also the first opportunity we have in general to put embryos back, unless we go for freeze-all. But these embryos are actually coming in a very aggressive, non-receptive situation. And there's some key studies that really indicate that how abnormal our endometrium gets if we don't correct this or try to correct this. And so a study from Ubaldi has shown in 1997 already that there were no clinical pregnancies in cycles where the endometrium is advanced more than 3 days. Later on, Kolobianakis has shown that the endometrial advancement is on average 2.5 days in antagonist cycles. And then it's not only the high steroid concentrations and the generation analogs we're using, but it's also the way we trigger. Many of us were at the debate yesterday, the dual trigger or just ACG trigger, and also agonist trigger, which extent we studied. All these way of triggering also impact our endometrial receptivity. So basically that's also changing it and may need some individualization for our luteal phase support. But then let's move away from this complicated fresh transfer and just move to the most natural of transfers, which is the transfer in the natural cycle. Natural cycle, the true natural cycle, so the cycle without ACG trigger. We just have our LH rise as we have in all natural cycles, and has been monitored in a study by the group of Nikos Polizos, and there was no luteal phase support given. And strikingly, what he saw, first of all, is that there was a cutoff of 10 nanogram, which has also been mentioned before, and has been come up in many studies, also in artificial cycles, as a cutoff for lower pregnancy rates. And he actually saw there was significantly lower pregnancy rate, clinical pregnancy rate, live birth in those patients where the progesterone levels in the serum test on the day of embryo transfer or the day before was below that threshold. Quite spectacular. So he had patients both with selected embryos, so PGTA tested, and also non-tested embryos. And in both, you can see it on the right-hand side, you see that same curve. The lower the serum progesterone, the lower the pregnancy rates. So this actually shows that what we think is natural and should be the ideal situation, typically the situation you can't further improve, should be good enough. But apparently it's not. So let's go further into the mechanisms here. So this study by Young has been assessing how much progesterone we actually need in the serum to have that secretory transformation. Okay? So patients were given different doses of progesterone intramuscularly, and then endometrial biopsies were taken, and had a look at how the secretory transformation happened and to what extent there was a delay. And actually we saw that very little progesterone is needed to have a secretory transformation, actually 2.5 milligrams, which is quite, not milligrams, it's quite a low dose. So basically very little is needed for the serum progesterone. Basically we're not talking about the uterine progesterone, to have a secretory transformation in the endometrium. Secondly, and it's also striking, I think many of you must ask this question to themselves, how come that we measure these serum progesterone levels if we don't see any relation with the progesterone levels we measure in the uterus? So because that's where we know the embryo is and where it needs to be receptive. But a nice study performed by Lynn Labarta has shown that if you take at the same time progesterone levels in the serum or in the uterus, that you have just totally unrelated concentrations. So this makes us realize that there are two roles of progesterone. So the slide doesn't move. Okay, so apparently the study showed no correlation. So this makes us realize that progesterone has both a role directly in the endometrium for the secretory transformation and implantation, also immunologically, but also that immunological change goes much wider than just the endometrium and actually affects the whole body, preparing it for pregnancy, and also importantly to maintain pregnancy, as we see with increased miscarriages in the absence or in the presence of too low progesterone levels. So let's have a look at another study. So just show the study where everything was done in the pure natural cycle, true natural, no ACG. But this study, published by Barbara Lawrence from the group of Human Fatimi, did it differently. So first of all, the triggering was basically not done by ACG, but they just followed the cycle with serum level measuring of LH, but also of progesterone. And we all know it's not LH that's causing the change, it's basically progesterone that's actually changing the endometrium. So then you have a better timing of the transformation and a better timing for transfer. And at the same time, luteal phase support with micronized progesterone was given to all these patients. Also, this study included only tested embryos. Only euploid blastocysts were transferred, so we minimized the effect of embryo quality on implantation outcome. And then you see these two curves, the blue and the red one. And the blue one is the one that's only corrected for age, BMI, embryo biopsy, cryo day, and embryo quality, those which we know to relate with implantation. But if you additionally corrected for progesterone measurements on the day of transfer, the curve didn't change. So basically this shows that in a natural cycle, if progesterone is added, basically you don't need to measure progesterone anymore because that value becomes irrelevant. All patients are adequately supplemented and pregnancy rates only depend on other variables, as we all know, such as age, embryo quality, and other patient characteristics. This has also been supported in randomized controlled trials. Here I present you a meta-analysis of the couple of trials that have been performed. There are not many, but you can clearly see from the diamonds here on the forest plot that they're all on the same side, all on the side of administering progesterone. So live birth rates are significantly higher in natural cycles where progesterone supplementation is given. It's on top of the endogenous progesterone. Clinical pregnancy rates are significantly higher. Miscarriage rates are significantly lower. If we then split up according to natural, true natural, so without ACG or the one who is modified, we can clearly see for the true natural the significance is there. For the other one, it's less clear because it tends to go in favor of progesterone, but there's so little data available that we can't clearly see it. But I have the impression that future study probably will support that. So then have a look at the artificial prepared frozen embryo transfer cycles. So it's more complex, because in these cycles you fully depend on progesterone. And there's no endogenous progesterone production, there's no ovulation, so there you really need to have the progesterone right. Many studies have been performed, and all of these studies, they produce these kinds of bell-shaped curves. You see pregnancy rates in function of increasing levels of serum progesterone, and we see that those with lower progesterone levels tend to have lower pregnancy rates. Many of them find cutoffs, and all these cutoffs seem to be different. And so cutoffs of 10 nanograms per ml, 9.2, 8.8, or even lower, 7, and so forth. So it's much varying progesterone levels cutoff, so it's not so clear what cutoff we should use. And there's been strategies developed for those of which we assume that progesterone level vaginally administered is not enough, that we need to kind of rescue that cycle. One important study which is often cited is a study by Elena Labarta, where she added subcutaneous progesterone in those patients where progesterone levels in the serum were considered too low. And then the study was followed up, pregnancy rates were followed up, live births were followed up, and apparently these pregnancy rates were the same as compared to those people who never had a low progesterone in the first place. It was also compared with a historic cohort, and also there a significant difference was seen. This was not a randomized controlled trials. Actually, there's never been one randomized controlled trials performed that this low progesterone can actually be rescued. It's only based on these retrospective or sometimes rare prospective studies based on disputable cutoffs in serum progesterone levels. We ourselves at our center have also performed a study. It's a retrospective cohort of, and it's been also a poster here at ESHRE, with over 1,000 cycles, consecutive cycles of patients who were supplemented with micronized progesterone 400, so 2 times 200 in the morning, 2 times 200 in the evening. And we took a cutoff of 5 nanograms per ml for our decision making to supplement to subcutaneous or not. So first of all, what we saw is a significant reduction in the number of patients who would need subcutaneous progesterone. While in most other studies, it's about 25 to 30% of patients who need these painful injections, which are also not so cheap, and that's for several weeks if they're pregnant. Only 3.9% of our patients were actually prescribed these subcutaneous injections, so the vast majority went on without. On the right-hand side, you see the ROC curve. You could see how progesterone on the day of embryo transfer was related with pregnancy outcome. We could see no relation. So basically, with this strategy, apparently in our hands, it seems to work. But it's important to acknowledge that all of us have different practices. So our patients may take their progesterone in the morning and in the evening. Some centers do it also at lunchtime, middle of the day. They do 3 times administration. And then the timing when we do our embryo transfers or when we do our blood tests may vary a lot. And this, of course, will very much influence the measurements we do, and of course also the conclusions we should draw out of this. Now, going back to these cutoffs, I've talked about the lower cutoffs, but there are studies also indicating that there could be a higher cutoff of progesterone levels in artificial cycles. So here you have this bell shape, but only in one of these studies where vaginal micronized progesterone is used, upper limit was found. And this was a study by John Jovic, Perth, Australia. And he used basically a non-commercial, self-prepared vaginal progesterone, and he saw above a certain threshold lower pregnancy rates. This same thing has also been seen in other studies. Here on the left-hand side, you see a study by the group of Peter Humayden. He had the very innovative idea to actually supplement those with a low progesterone level with rectal progesterone. And rectal progesterone, of course, gets very well absorbed, and also he found it's significant lower pregnancy rates for those above a certain threshold. This 14.50 nanogram per ml, lower pregnancy rates were seen. And also surprising about this study is that it was very well tolerated by the patients, which many of us wouldn't have expected before the study. And on the other side, you see data from Milo, his paper in Human Reproduction from 2022, where he looked at all kinds of supplementation, and he found here, for those who are only supplemented with subcutaneous progesterone, there also appeared the threshold of 16. For those who only treated with that, above 16 nanogram per ml, lower pregnancy rates were found. And how can all this be explained? It's still part of our black box, I think. But what we do know is that the bioavailability of progesterone very much depends on how it is administered. So if you measure serum progesterone in the blood after a subcutaneous or intramuscular injection, or you measure it in the uterus, you find very different concentrations. So on the left-hand side, you see the serum progesterone, and in blue is the micronized progesterone. So it increases very slowly in the blood. But if you give the subcutaneous or intramuscular one, it shoots up much faster. And on the other hand, if you look at the endometrium, the micronized progesterone is able to provide much higher concentrations of progesterone locally in the uterus as compared to intramuscular, which is, on the other hand, is the opposite, much lower. With all this, I would like to come to my conclusion with a few take-home messages. I think it doesn't need any further explanation that progesterone has that crucial role in all aspects of embryo implantation and the maintenance also of pregnancy. So both the timing of endometrial progesterone exposure as well as the concentration, and so also in the serum as in the uterus, is important. From the clinical perspective, we see that the natural cycle has now become very simple. It's very simple. Luteal phase support for all makes the measurement completely irrelevant and no longer necessary, and saves our patients some burden of all these blood tests. For us as clinicians, the same of checking all these blood results. And then for the artificial prepared frozen embryo transfer cycles, there is still uncertainty. We don't know about these cutoffs. We need to study more into this, and we need to do the proper trials and be aware of our own center-specific ways of measuring and administering progesterone. Thank you very much for your attention.
Thank you very much, Dominique, and there will be time for questioning afterwards. Thank you.
Thank you, Peter. So we will continue with the second and at the same time the last speaker of this symposium. And his talk will be focusing on new waves in using the natural cycle as a source for embryo replacement. And Professor Samuel Santos Ribeiro is the clinical director and scientific coordinator of the ESHRE in Lisbon. And he will show us new ways to make the natural cycle for frozen embryo replacement more flexible. So Samuel, give it a go and convince us.
I will. I'll try my best. Thank you very much, Frank. Thank you also to all of you for being here in this very packed room. I'm very excited to talk to you about the new avenues that are coming out for frozen embryo transfer, and also that we can have this open discussion on this topic, which is more and more important. Yes. Oh, so I'm not only shorter, I'm farther away. So I will come over here. This way it's easier for you to see me and hear me as well. I did like and do believe that it's very important to us to first think why it's important to assess better and better the way that we do frozen embryo transfers. I'm showing you data coming from the most recent registry analysis, specifically in Europe, which is collected on a regular basis by ESHRE. And what we are seeing here is something that we saw a little bit earlier in the United States as well, which is that our pregnancy rates and also the quantity of babies that are being born after frozen embryo transfer have increased and actually surpassed those of fresh embryo transfers. Now, some people many times ask the question whether is this happening because frozen embryo transfer gives you a better context for your pregnancy and having better pregnancy rates to that extent. Well, I show you the data from our own clinic. It's presented in a poster as well this year by Dr. Sergio Suarez. And what you notice here is indeed that it seems like the fresh embryo transfer cycles are delivering better pregnancy rates when compared to the frozen embryo transfers. However, when you really look into the data, you actually notice that the majority of our transfers are performed by frozen embryo transfer. So the most likely result, the most likely reason why the pregnancy rate seems to be better in the frozen embryo transfer is probably because it's our patients with a little amount of eggs that don't have enough possibility to do PGT, that didn't have many embryos, that are actually also doing, as a backup, fresh embryo transfer. So I still believe that it's up to debate to argue that we will be precluding fresh embryo transfer to all our patients. Now, I'm not going to ask for a raise of hands, but I am going to ask you to think about internally, what is the type of frozen embryo transfer that you do more? And generally speaking, there are artificial cycles and there are true or modified natural cycles being performed, and can we do others? I think it is important for us to have this discussion because it's alluding to how we treat our patients and why we make these decisions on a clinical basis and how much they can affect our patients. What, however, is the most usual comparison and the most spoken topics that have been increasing ultimately in the most recent years is when you're comparing nature versus artificial, so natural cycles versus artificial cycles, it's mostly about a question of safety. And the one that has garnished the most amount of discussion and concern is hypertensive disorders in pregnancy. And this has been something that has been shown around regardless where you are stated. In the States, in Sweden, in China, even inclusively in the Iberian Peninsula, when you look at the oocyte donation model. And I think that it's important to use the oocyte donation model in this context, because with that way you're also removing any possible metabolic diseases that can be causing the condition here. So regardless of how you look at the data, it does seem, at least in these retrospective or registry data analyses, that the preeclampsia or hypertensive disorders seem to be more risky or more common in the artificial cycle. These sort of data have been complemented recently by Zat et al. In human reproduction updates. And in this analysis, which was very thorough, not only preeclampsia was assessed, but also even preterm birth was assessed as a finding, which was important. Additionally, luteal phase support was also shown to be very important, especially for preterm birth. So it seems, in this least graphical abstract, that natural frozen embryo transfer cycles could be something that you may be thinking if you want to have a safer approach. There is, however, another outcome which is also being talked about. Yeah, I would argue more controversially, which is the effects on potential increased risk of miscarriage. There are some studies that are alluding to the fact that there may be more miscarriage, but not enough to affect live birth rates, and others, on the contrary, would actually say that there doesn't seem to be much more miscarriage, but actually it could affect live birth rates. One thing that I do believe, and Dominique alluded to that now, is that we are entering into a new zone, and that monitoring progesterone, especially in the artificial cycles, could help in the assessment and reduction of the risk of miscarriage if you do it correctly. And coming from the work of Melo et al., assessing that effect specifically on miscarriage, that's what could be seen in those that had low progesterone values. I'm going to show you, however, a study which I think was interesting and that we presented last year in ESHRE. The first author was Felipa Rafael, and she presented an assessment of, again, in oocyte donation model, using over 30,000 patients, comparing the artificial versus the natural cycle. So there are many things that are important to say here. The first of all is that it's a retrospective study, so it's very likely that physicians chose this based on things such as health of the general patients. But our main question there was, if we are looking at a potential risk to an older population, and who is electively the older population, those that are patients doing oocyte donation, can the natural cycle be safely done in the older population. So this is the overall sample, 30,000 patients comparing artificial and natural cycles. And I don't put any p-values, but it's actually all of them are statistically significant. Are they clinically relevant, the differences? I would argue no. These are very small numbers in a very, very big sample. However, I present you this study because I think that the second part is interesting. The study also had a subgroup of cycles which were already performed using not only progesterone monitoring, but also progesterone rescue therapies whenever progesterone was low. And what you notice is this is something that did not eliminate the increased risk of miscarriage in the patients performing an artificial cycle. I again wouldn't argue that the live birth increase, although statistically significant, is completely there for sure, but I do think that it's interesting to say that consistently miscarriage was seen in this context, not being repaired by the use and the correction of progesterone. There's one study new and that has just come out, and I couldn't ignore it because it's a very big, very important, and a very valuable study for our context. And this is the MONAD study coming from the group of Vietnam. They assessed the possibility of having live birth, not only in true natural, but also in modified natural and artificial cycles. There are some things there that were being evaluated that we don't do in current practice, the lack of monitoring of progesterone, luteal phase support that wasn't used. However, I still think that this is a very important study to give us data on live birth outcomes. Now, most of the studies and the data that we had from before from our randomized control styles didn't show any differences in terms of pregnancy rates, and that's what you see again in this study. However, what people wanted already, and although we tried to have it, were signals in terms of perinatal data. And again, this study didn't show any differences between the groups, contradicting that what we are seeing not only from the meta-analyses, but the other retrospective studies that I asked you. So it would be a very fair question to say, could we end this discussion? And RCT says that there are no differences in perinatal outcomes. The retrospective studies are not as robust. Well, I would guide you to the response that the actual authors gave, which is their study admittedly isn't large enough to be able to assess perinatal data. And I am very hopeful that if we do wait for the larger and ongoing RCTs specifically on this topic, specifically looking at patients that are performing PGTA, specifically at those also assessing progesterone levels, we may have a final answer for this. And I hope that we'll be able to help our patients more further in this assessment. However, I do believe the question's open for debate, and that we still need to discuss why is the reason that artificial cycles continue to be the predominant cycle strategy in a population of patients which are much older than the 33 years old of age that was presented in the Vietnam data. I don't know about your centers, but in my center, the average age varies around 40 years of age, where preeclampsia and miscarriage is much more common. Well, when we look at the pros, it's the ones we've been discussing at length until now, but when we look at the cons of artificial cycles, it's very fair to say that it's not a perfect situation. You have much less flexibility, you have much higher cancellation rates, it's only for cycling women, and in the previous study, 20% of the cycling women couldn't do a natural cycle either, so it's not at all spectacular to do. The question here is, what can we do to tackle these issues? One possible solution, and which I'm very excited to present to you today, is the possibility of garnishing the main advantages from the natural cycle and the main advantages from the artificial cycle in terms of flexibility, and trying to give the best that we can to our patients. And first, let me go through with you what is the rationale around what we call the natural proliferative phase frozen embryo transfer cycle. Well, the first thing we need to know is that why we need the two hormones, estrogen and progesterone. And estrogen, we know, is super important for endometrial proliferation, and that we can take advantage of just by letting the cycle flow naturally in a patient with an ovulatory cycle. In the second part, we know that then comes progesterone. And as Dominique was presenting, progesterone is very important for the initiation of the secretory phase of the endometrium. However, he did also allude to a very important topic, which is that progesterone starts to rise ever so slightly just before ovulation. And in fact, if you inhibit that progesterone elevation, ovulation does not occur, according to more than one study in both the animal and human models. So progesterone, according to some studies, could actually be used as a potential trigger to cause ovulation to occur. So the possible solution that came out of here was thus to allow the natural progression of endometrium to occur, to allow a follicle to develop. And once your endometrium was at least 7 millimeters, and once you had a nice follicle of at least 14 millimeters, so long as your progesterone was okay in the serum blood, well, then you would just start micronized progesterone at a dose of 400 milligrams, so 2 times 200 milligrams twice a day. This is the so-called natural proliferative phase cycle in our centers. Others call it the programmed ovulatory phase natural embryo transfer cycle. Another advantage which is quite common around this concept is, what do I do if I have an LH peak? If I have this LH peak on Monday, making me have a transfer on Sunday, which I would like to avoid. Well, with NPP, the cycles with an elevated LH are welcome as well, because you just start the progesterone and you can do the transfer somewhat earlier, and a day earlier to be more specific. These are the data that Catalina Godinho from our group presented just this year in April. And again, a retrospective data. This needs to be confirmed prospectively, but showing very interesting outcomes in terms of both ACG positive pregnancy outcomes and also live birth outcomes, comparing these 3 strategies, both the natural, the artificial, and the live birth outcome. And again, you do see something that we were seeing from the oocyte donation assessments, which was this increased risk of miscarriage in those performing artificial cycles. There's one comparator which I also think is important to assess here, is in terms of the number of visits that one had, and also the progesterone levels that you had on the day of the embryo transfer. And by the way, for those that are questioning, the values that you had here presented are by nanograms per milliliter. What you saw both in the cycle that had natural proliferative phase and also natural cycle was very stable and very comparable levels of serum progesterone in both those strategies. Meanwhile, the artificial cycle had very borderline levels of around 10.04. So the need for rescue progesterone strategies was much more common and knowingly common in the artificial cycle. And for us, the interesting outcome was to understand that in the NPP protocol, it didn't seem like there were the need for so much frequent use of rescue progesterone. Again, if you're looking for perinatal data, you need very large samples, and we in this study only have 369 patients performing NPP, but it is interesting to see that once again, the artificial cycles was associated with higher hypertensive disorders. Meanwhile, the natural and the NPP cycles seem to have very comparable and very similar artificial hypertensive disorders degrees. And yeah, in the population, that is our current population. So not in 33-year-olds or in 32-year-olds performing the treatment. I do believe there's a lot of missing data. You're missing prospective studies, preferably randomized studies showing you that this is correct. There is also an importance in terms of the physiology. We're all assuming that ovulation occurs, but is it occurring physically, or is it simply just not being inhibited? Is any of these occurring? Is the oocyte that is being produced competent is also one of the questions that we want to assess. And one of our other fears is, in a cycle that is being done by a less experienced physician, is the poorly monitoring increasing your risk of having low progesterone levels? So again, going back to a completely artificial cycle. We currently have 2 prospective studies ongoing to assess all these questions, to see if we are able to give more rationale to the results that we found. I hope to be able to tell you these results the next time that we are here. in a nutshell, I understand that completely precluding the use of ACG and completely believing that we won't need ACG for our treatments can be something daunting. So I will be completely okay with the fact that you're not ready to hop on the NPP train yet. And I actually think it's a smart idea because we need to wait for the prospective studies. But there are still things that you can do in your older population that can have a corpus luteum to help you to use the natural frozen embryo transfer cycle and still leverage all the potential power from the corpus luteum that you can generate. One potential possibility, which is quite commonly used in the United States, is to use low-dose stimulation and low-dose antagonist suppression to be able to form or to go over the weekend to avoid any possibility of having weekend transfers. This is something you can do. You could also consider flexible ACG triggering or triggering with follicles of smaller dimensions. This was presented by the group of EV Madrid and showing follicles of 13 to over 19 millimeters showed quite comparable pregnancy outcomes regardless of the measurement that you had of the follicle. These sort of strategies cumulatively would give you the possibility to work out your frozen embryo transfer cycle in a way that it will be more balanced. And I'm sure that not only the physicians, but also the embryologists would deeply appreciate this possibility. There's also one more, which is, I would argue, more controversial because it's less studied, but it would also be a very interesting part of research. There are some groups in Spain, and namely in Portugal, which are performing flexible LPS, which means giving your ACG, but starting your progesterone earlier to try and avoid weekends or days with more activity. All these are for those that are not ready to forego their ACG, which they love, strategies that can help you enhance the possibility of using a natural cycle in your current practice. So my take-home messages would be, I believe honestly that we should be saying no to a frozen embryo transfer strategy for all. I am indeed advocating that we use more natural cycles, but I do believe that the artificial cycle is here to stay as well, that we'll continue to need to use it, and that the research in reducing the risks that seem to be associated with it needs to continue. The idea, however, is in the meantime that we investigate more and that we embrace more the possibility of the patients that we have can use a corpus luteum whenever there is a possibility. And there are multiple strategies that I believe that already are in place, which you can test with. I hope that we will be able to use NPP, however, as the future of the natural frozen embryo transfer cycle. Thank you very much for your attention.
Professor Santos, thank you very much for a very intriguing and inviting lecture. And I would like to ask Professor Stoop and you to come both to the microphone at the presenter position. So we will sit here because we have a transporter here, and we'll do some work on questioning you on your perfect lecture, because even in a perfect lecture, there can be some weaker points that may become addressed. So Peter will first talk to Dominic.
Actually, I think I'm going to talk first to Samuel because I want to be the devil's advocate as long as you remember his lecture. So Samuel, you just showed us that we can actually have quite a high degree of flexibility if we use a modified natural cycle, because we can trigger at follicle sizes of 13, 14, 15, 16, 17, and 18. So this is one injection. And then you also, or maybe Dominique showed me that actually it seems as if luteal phase support is not necessary in the meta-analysis that we saw until now if you use the modified natural cycle. So one injection, no luteal phase support versus daily luteal phase support in the NPP protocol. So what do you think about this?
Yeah, it's a super interesting question. I do believe, however, that that's the only unstudied question. So what was studied in the study from Carlos Alonso is the use of ACG with luteal phase support. Okay. So we're still missing evidence that the corpus luteum will be as competent. I do believe that we will have that evidence from the NPP data, but for those that are weary on using, on foregoing ACG for now, I would continue to use the luteal phase support until you have the data.
Okay, and then the next question for Dominique. So Dominique, when we talk about monitoring progesterone, we face problems during natural cycle, and you were saying, okay, we don't need to monitor as long as we do luteal phase support. Now, for the artificial cycles, I think there's still a lot of confusion in terms of standardization, no standardization, etc. Could you just say something about this?
Yes, as your own studies have shown, estradiol also probably plays a role, and I think very few of us are measuring that at the moment, so I think we may have to expand the measurements with that regard, or at least some of us in the research setting, to see what cutoffs there could be and where we could learn from that. But on the other hand, in the natural cycle, I think that we can actually stop monitoring as long as we give luteal phase support, although even there, estrogens also may need to be assessed whether they could play a role.
I was aiming at progesterone monitoring.
Of course, progesterone monitoring is no longer needed, I think, in a natural cycle.
No, and for the artificial cycle?
Artificial cycle, I think it still makes sense to monitor it. At least we do this just to gather data, and also to gather data on the estrogen levels.
And again, you know, I wanted you to expand on standardization versus...
The standardization is not so easy to do. We can standardize how we ask our patients to take the vaginal luteal phase support in morning and evening. That's what most of them do now, 400 morning and evening. But then typically, at least in our clinic, the blood tests are done when they just come for an embryo transfer. And that can differ very much from clinic to clinic. It can happen in the morning, can happen late in the afternoon. And busy clinics can happen over multiple hours of transfer. So if you don't interpret these cutoffs, it's going to be quite challenging. So standardization is important, and that's also one of the limitations we've seen in literature so far. Many studies did not properly randomize, or did not standardize, especially those who are retrospective studies.
Okay, good answers. I want to come back to your lecture, Professor Santos, because there seems to be a kind of struggle between artificial and natural cycle as a source for the frozen embryos. And you alluded to the question, what is the audience using in our daily work? And you said you wouldn't ask for raising hands, but I would suggest to do so that you know how many missionary work there is still left for you. So we make a poll. Who is using artificial cycles standardly for the embryo replacement after freezing? And who is using standard natural cycle, maybe modified or any other slight variation? 50-50. Yeah. And this is, I think, a draw. Are there people who do not do frozen embryo replacement cycles? Or are there any people in the floor who do cardiac surgery? There must be some different specialty. Okay, we'll discuss that later. So there seems to be an equal distribution between artificial and natural, and with your NPP approach, you wish to see more natural cycle usage because we restore the normal corpus luteum. We support it a bit because nature is not perfect. But do you think you will win the match in that way?
It's a good question. The objective is to do the best for our patients. If at the end I need to lose, I'm happy to do it so long as it's the best for our patients. However, I do believe that we have a lot of data now to show that if we're doing mostly artificial cycles, because we want to avoid the weekends, that there are other strategies, and that we're not doing the best to our patients to that extent.
So can I just ask you also, do you think we are thinking too simplistic? Because I think the majority here will say, well, it's a matter of relaxing or no. But I mean, the corpus luteum is very complex, produces a lot of substances. Is this so simplistic that it's just a matter of relaxing?
No, it's very likely that we're unable to completely understand the full amount of how much blackness is in the box, right? So there I would even go to the fact that since we don't know, let's try and attach or play around as less as possible, and at least let the corpus luteum to continue to exist. And I also think that the levels of progesterone that you're able to reach may be important for anything that is systemic, which is something that we're not looking at when we're looking simply at values of 10 or 11 or 12 for implantation.
So I'm looking a bit to my co-chairperson. Do we have any important questions left?
No, I don't think so, actually. I think we covered most of it, unless someone from the audience has a very good question to ask. You're welcome. Yeah, okay.
Yeah, use the microphone,
Use
please.
the microphone and state your name and country.
Hussam El-Zini from Australia. I think with the frozen embryo transfer cycles, the HRT cycles, we know the association between it and hypertensive disorders of pregnancy. But there is some evidence coming, and there is an abstract this year that said that it's not the artificial hormones itself. It is probably the reason, because you are doing the artificial cycle mostly for patients who are having polycystic ovarian syndrome or disorders like that. And I am myself not convinced that a corpus luteum that can just stay in the first trimester has an effect later on the hypertensive disorders of pregnancy. So what's your opinion about that?
Yeah, so so I would argue that the jury is still out on that context, but the majority of the data that you will seeing is indeed retrospective, and you will not be able to weave out completely this assessment. I do believe, however, that with the new RCTs coming out, specifically 2 of them that are looking at PGT data with older women, that you will be able to make a more clear response on that, because specifically speaking, PCOS was monitored and also potentially excluded in that situation. I'm sure that the background diseases will have some effect, but you can also see this in the ovulatory patients that don't have it, right? So I can't believe that only PCOS will be the reason.
Thank you very much. So one short question and one short answer.
Okay, thank you. Ariel Wiseman from Israel. I have a question. Can you appreciate to what extent are natural ovulations blocked by the administration of progesterone? Like it is done in the PPOS, you can do flexible PPOS. So perhaps you are losing the advantages of having a corpus luteum.
Yeah.
Can you measure it? Do you have any idea how to do it?
So the prospective study is actually to close that question, because that question is super frequent, which is, aren't you actually doing the opposite, blocking it? Well, we have some preliminary data to say that likely we're not. The first one is the fact that the progesterone levels are relatively high. They're exactly the same as a natural cycle. So is the rescue progesterone. Also, something which we described also in the article that came out is that we literally see the corpus luteum. So we know that it's there. What I don't believe that is clear is are we not inhibiting ovulation to eventually occur, or are we actually triggering? That question, I believe, is up to discussion. The study that is looking at that will also reply if it actually doesn't exist.
Thank you.
Okay, thank you very much for your contribution. I wish to close this session by stating that we see that this symposium has really contributed to the search for the insights of the black box, with a focus on the importance of luteal support using the natural progesterone, and also the potential benefits of using the natural corpus luteum. And I think the work on the agonist trigger that has been done in the past years has helped to open this black box. Also, we emphasize the role for micronized natural progesterone, helping the natural corpus luteum to function to the benefit of the implantation process. And the reason for this emphasis is that the micronized progesterone, the natural progesterone, has the largest body of studies and evidence to support the use of it for our luteal support purposes. And with that, I close the session. I thank the two excellent speakers for their contributions, well appreciated, and I wish you a good continuation of this symposium.